Good evening, sir. My topic is causes of awareness under anesthesia and management, sir. Awareness is defined as a unexpected and explicit recall of sensory perception during general anesthesia, also defined as accidental awareness during general anesthesia, also known as anesthesia awareness with recall. Incidence of intraoperative awareness is 1 to 2 cases out of every 1,000 patients who receive general anesthesia. It is higher among cardiac cases, 1 to 1.5%, and obstetric cases, 0.4%. Accidental awareness during general anesthesia is defined as a spontaneous report by a patient that he or she has been aware at a time during anesthesia and surgery when the patient is expected to be unconscious. Types of intraoperative awareness. First, explicit awareness. Conscious recollection of events either spontaneously or as a result of direct questioning. Implicit awareness is defined as exists without conscious recall, but they can alter patient's behavior after the event. Risk factors of intraoperative awareness. Most common one is whenever neuromuscular blocking drugs are used, obesity, predicted difficult intubation, general anesthesia for cesarean section, rapid sequence induction of anesthesia where neuromuscular blockade is administered before checking for unconsciousness after a prejudged dose of anesthetic. Total intravenous anesthesia in the presence of neuromuscular blockade, emergency surgery in critically ill patients where it may be necessary to limit concentration of anesthesia to aid cardiovascular stability. Past history of intraoperative awareness. Causes of intraoperative awareness. First, intentional provision of light anesthesia in high-risk patients such as massive bleeding with severe hypovolemia, decreased cardiopulmonary reserve such as EF less than 30%, severe aortic stenosis, severe ventricular dysfunction, and low cardiac index. It is seen in other surgeries such as cesarean section and cardiac surgeries. Reason for it is volatile anesthetics cause depression of myocardial contractility and vasodilatation. These hemodynamic effects would be poorly tolerated by patients with low cardiopulmonary reserve or those who are hypovolemic in case of trauma. In cesarean section, there is a tendency to decrease the amount of volatile anesthetic used and to omit narcotics till the delivery of the baby to avoid neonatal respiratory depression. These patients may be particularly light in the short time interval between endotracheal intubation and delivery of the baby. Second common cause of intraoperative awareness is inadvertent provision of light anesthesia, such as prolonged attempts at laryngoscopy and intubation after a routine induction dose of anesthetic agents, difficult airway management, during patient transport from induction room to operating room, indiscriminate use of non-depolarizing muscle relaxants, relying on fixed minimum alveolar concentration values of volatile anesthetics agent for all patients, malfunction of anesthetic delivery systems such as vaporizer or infusion pumps, misuse of equipment like not turning on the vaporizer or not programming infusion pumps, inattention to end tidal agent monitor values or these values. Third, increased anesthetic requirements is seen in tolerance to anesthetic agents such as use of alcohol, smoking, opioid addiction, chronic exposure to subanesthetic concentration of anesthetic agents. Preventive measures of intraoperative awareness. First, various measures have been recommended to reduce the incidence of awareness. Pre-induction measures. We can reduce the intraoperative awareness by pre-medication with amnesic drugs such as benzodiazepines, by meticulous checking of the anesthesia delivery system before induction, by intraoperative monitoring, clinical techniques used to assess intraoperative consciousness such as checking for movement, response to commands, eyelash reflex, pupillary responses, respiratory pattern, perspiration and tearing. Conventional monitoring systems which are used are ECG, blood pressure, heart rate, end tidal anesthetic agent concentration. Use of gas analyzers to detect and display end tidal anesthetic agent concentration. Amnesia is produced with subanesthetic doses of volatile agents, 0.3 to 0.5 minimum alveolar concentration. Unconsciousness is provided by 0.8 to 1 MAC. Third one is brain electrical activity monitoring. Most commonly used one to detect is bispectral index. It ranges from 0 to 100. 0 denotes absence of brain activity. 100 means completely awake state. 40 to 60 is adequate for general anesthesia to prevent awareness. Detection of awareness. Awareness is detected post-operatively either by spontaneous self-reporting by patients or by direct questioning. Gold standard for detection of intraoperative awareness is modified Brace questionnaire. Consequences of intraoperative awarenesses are fear, panic, nightmares, inability to sleep, helplessness, anxiety, post-traumatic stress disorder. Management. First step is to listen to the patient's experience and to acknowledge and document in the case record. Patients should be reassured and explained about the possibility of bad memories, dreams, and flashbacks, which will resolve with time. Referral to psychologists for thorough assessment and treatment should be done. Thank you, sir.